patient has not gone for cirrhosis at that point of time. So the patient suppressive pathway is going to get implemented. At that point, the patient nutrition, immunity, sarcopenia, all those things is going to get taken. That's why I'm telling you. So whenever you're going to use a molecule, we need to address the patient completely to whom we are going to use, to which presentation we are going to tackle. That's how we need to tackle this kind of thing. Based upon this paper, it shows a reasonable response, better response to than your H2 receptor antagonists. Few points about your H2 receptor antagonists. Adverse events is very low. One common problematic thing is tachyphylaxis. What is tachyphylaxis? If you are going to use for prolonged duration, the response is obviously is going to come down. So that's what is tachyphylaxis. As you all know, simulated, very common molecule because of your GA, gynec problems and gynecomastia, other adverse events, it has been complete for duration of therapy. That's what some people have been trying. But in pantoprazole based regimen, what I am mentioning that the significance with a probability will not be that high to prove that you are having dementia risk when you are going to do it. Again, this is still question because in some papers we are mentioning that multiple sclerosis, for example, even in neurology journal, we frequently will be seeing that multiple sclerosis and Alzheimer's and other presentation, your PPI may worsen that kind of scenario. That's what some papers have mentioned. So this is how we need to get addressed. Not all the presentation will go together because PPI is very rampantly, commonly used molecule. When you are going to use this kind of molecule, always addressing the patient as a whole is very, very important. That is the major presentation. Cardiac morbidity is very common scenario. Always you need to be very cautious when you are going to use your PPI. The best one is H2 blocker. And H2 blockers, the adverse events is extremely low. You should remember in PPI, the adverse events is huge, starting from airway disturbance, sodium, passion, ovulation, and your cardiovascular, your neurological dementia. For example, gastric hypertrophy. There are proven malignancy risk factors. I have seen multiple patients who will be using PPI. When you are going to do endoscopy, you will be identifying multiple polyps. That's called hypoplastic polyps. So once a patient is going to land with hypoplastic polyp, if it is few number, we can remove by polypectomy. But if the patient is having multiple, like your familial polyposis, that point you cannot treat anything. At that point, we need to wait and watch. The patient may go for million transformation. But fortunately, based upon your PPI therapy, even when the patient is going for funding hyperplasia, at that point, even when you are going to identify the patient endoscopy, over a period of time, we follow. The risk of progression to malignancy is slightly lower, only because of PPI alone. That's one good thing we can compare. Even the patient is having risk. But this kind of patients, there is a possibility for them to go for GA bleed. But that is one complication we need to get addressed. Apart from that,
many patients who will carry a file where the prescription will be probably 15 years old, faithfully following the prescription, they will probably pronounce that also. I follow the prescription of that doctor. The doctor would have been dead and gone in COVID, but his prescription will be valid in the file.
so when you are using for a patient for more than 12 weeks of